Morning.
Good morning, Gadoni. Good morning, Evans. How are you?
Morning. Morning to you.
All right. Karibuni sana. I hope you guys can hear me well.
I can hear you well.
All right. Thank you so much. I can see we have a good quorum. So thank you so much, everyone who has joined us today. This week has been customer service week, and as a way of giving back to our customer, we thought having a session on mental health and wellness will be the best way, and I agree. So karibuni sana. Allow me to welcome Dr. Ivan Sole. He will be the one taking us through the session, and I will be looking at the chat box to see if we have any questions. So guys, ensure that you ask as many questions as possible. So karibuni sana. Karibu, Mr. Ivan.
Thank you very much.
Thank you, Agnes, for that. Before we welcome Dr. Evans, my name is Garoni Bugwa. I am a clinical psychologist, and I would like to thank APA for doing this webinar with us at Chiromo Mental Health Hospital. Chiromo started in 1997 as a single facility at Westlands. But now we've grown to 3 facilities. We have Chiromo Westlands, Chiromo Braeside, and we also have the Chiromo Mental Health Hospital on Mudangari, which is the new Bustani, with a bed capacity of now 180. We have 22 psychologists, and our vision is to continue providing dignified mental health care in Africa, and to provide evidence-based practice. For today's conversation, we will start with Dr. Judy first, followed by Evans, and as Agnes has said, we will then go to the Q&A session. Dr. Judy?
Okay. Thank
Please
you.
Welcome.
Okay. Thank you, Gadoni. I am Dr. Judy Kamau. I'm a psychiatrist, part of the Chiromo mental hospital family. The office is also there. I also see patients for the hospital itself, and I'm also in private practice. So I'll be taking you through mental health and wellness. So give me a minute to share my slides, and then we can proceed. Oh, I don't know if you've disabled screen sharing. I get the part for host has
just a disabled.
Minute. Yeah.
Can you share now?
Yes, I think I can. Nice. Oh, yeah, just a minute.
Dr. Judy?
Yeah, just a minute.
Okay.
Yeah, just a minute. Am I on? You can see my screen now?
Yes.
Okay. Now, are we good?
Yes.
Okay, good. So as we've just mentioned with Dadoni, we are part of the Chiromo Mental Health Hospital. So we are glad to be with you this morning, talking to the APA team. As I mentioned, my topic is more or less mental health and wellness in terms of how to promote it, what is mental health. So we usually talk about health most of the time. This definition is by the World Health Organization. And health is usually defined as a state of complete physical and mental, social well-being, and not merely the absence of disease or infirmity. So which means that in this definition, we're not just looking at physical health, we're looking at mental and social well-being, and that's where we come in. Physical health, mostly people go to the physician or the general practitioner, even for mental health problems, but for some reason, over time, mental health has been looked at as something very foreign. So what is mental health? So according to the World Health Organization, it is a state of well-being in which every individual realizes their own potential, can cope with normal life stresses, can work productively, fruitfully, and is able to make a contribution to the community. So if you're not able to do many of these things, then we would be concerned about your mental health. So when we talk about realizing your own potential or coping with normal life stresses, these things are usually what happens in your day-to-day activities. But if they impair your ability to work productively or even to be able to enjoy yourself, then we would say your mental health is being impaired. So that's what we mean by, so that's basically the definition of mental health. So this is just basically good mental health. So you can have someone who has poor mental health, and we'll talk about the signs that we usually look out for, the causes of poor mental health. And then we'll also end with how to promote or what to do when someone to improve your mental health, and also what to do if someone has problems with their mental health. So what are causes of mental illness? So what are the causes of the things that we've just alluded to that would make you not function properly, for example? So we usually talk about vulnerabilities, and there are people who are more vulnerable to having mental health problems than others. So here we're talking about genes and family history. You'll usually hear of someone who has had a history of mental health problems in their family, or that someone may have either attempted or completed suicide. So those things make you more vulnerable to mental health problems as an individual. Same thing with life experiences, such as stress or history of abuse. And we're talking about maybe even physical abuse, childhood traumas. This can make you more vulnerable to getting mental health problems. When I say vulnerable, it means that it's not 100% that you will get mental health problems if you have a genetic family history, but you're more vulnerable to having mental health problems. Where you've been living in extremes of circumstances or been faced with disaster, either man-made or even natural disasters, the sequelae that comes with it, the destruction, the loss of life, loss of economic state, usually makes you more vulnerable. Then we also have biological factors, or what we call chemical, where you have chemical imbalances in the brain. This just makes us realize that mental health problems are not just something that we come up with. They're actually biological factors that contribute to mental illnesses. Use of alcohol or recreational drugs make you more vulnerable to mental health problems and also cause mental health problems. Sometimes people will use alcohol or recreational drugs to self-medicate themselves. There's a pick-me-up. So, and then after that, that becomes a problem. So it becomes like a cycle. You're using it to treat yourself. You already had an underlying problem. However, it will also lead to you having other issues as well. Now you face things with addiction, anxiety, things like that. Having a serious medical condition like cancer makes you more vulnerable. You have a lot of psychological stresses that come with it. The fear of the unknown, always waiting to maybe a cancer will relapse, even if you're cancer free, it still makes you more vulnerable. There's the expenses that come with it. Isolation, physical, deformities and things like that make you more vulnerable. Having a few friends, feeling lonely and isolated. Case in point, the period that we are in, we are having states where someone was already isolated and now they're just alone with their own thoughts, especially in this COVID time. You've lost a job, you have to stay home, you have to isolate. It really takes a toll. Even for the patients who had maybe COVID-19, an infection, we would find they're more vulnerable to when they have that isolation and they have to stay away, especially when they're maybe physically ill, very physically ill, and they have to isolate or they have to be admitted and no family is visiting. That usually takes a toll, and it's been seen actually recently to quite take a toll on our patients. I touched on medical illnesses like cancer. So here, it's not just the illness itself. So when we look at it, we look at medication sometimes used. So some of the, maybe for example, some treatments that we use can also make you more susceptible to having a mental health problems. Heavy use on steroids makes you even more prone to other medical conditions that also have an effect on your mental health problems. Some medications that have been used in the past for things like hypertension, especially, would also sometimes make someone more prone to depression as a side effect, and sometimes it endures. So medication also in a physical illness. The disease itself, diabetes is one of those illnesses that actually come together with depression. So usually talk about a triad with diabetes. We're talking about hypertension, cardiovascular disease, diabetes, and obesity. But then we also throw in mental health problems, mainly depression, because of hormonal issues and also the disease status itself. Men are sometimes more prone to, when we're talking about mental health problems, sometimes they have generally poor health compared to women. They go to hospital late, they sometimes just dismiss things, and so they'll present when the illness is a bit more on the severe side. Patients who have hypertension earlier in life, I already mentioned obesity. Obesity in itself comes with other issues as well, both physical and mental in itself. These other ones that we're just talking down, we've highlighted down there, stroke, especially if your stroke would affect the frontal part of your brain, you're more prone to having other mental health issues. Even some get psychotic symptoms where they start seeing things that are really not there, or hearing voices, or having personality changes. Alzheimer's disease is an illness that affects your cognition in terms of memory, especially, and day-to-day functioning, and also tends to come with itself other mental health problems. You can have patients being psychotic, others have problems with sleep, others have depression on top of it, especially when they're having those periods between memory losses and times when they are well. During the times when they are having memory losses, they tend to have also present with symptoms of depression. Chronic kidney disease, hormonal in nature, and also the fact that this illness can take a toll. You're going for dialysis, you may have poor family support. It makes you even more vulnerable. So we mentioned chemical imbalance and mental health. We mentioned chemical imbalances earlier. There's something we call serotonin. This is a neurotransmitter. Neurotransmitters are small, tiny molecules or chemicals in the brain that help in cell-to-cell transmission or messaging. Yeah. So serotonin is one of them, and it's really associated with things like depression and sometimes also with schizophrenia. Especially when your serotonin levels are low, you're more likely to get something like depression. dopamine, also mood disorders, and with schizophrenia. We have norepinephrine as well, associated a lot with anxiety. So those are the things that will go off, and then we have to correct them sometimes with medication. We also talk about endorphins. So endorphins are things that are produced by the body and then they help in relieving of stress and pain. So they work like an opioid for example, one of those painkillers in that class. So we naturally can produce endorphins. They are feel-good hormones. They make you feel good after. So that's why you will find after maybe yoga or meditation or after some exercise, you'll find that you kind of feel good in terms of your mental health. You've produced endorphins and they kind of feel good like hormones. So, and when someone is low on their endorphins, then things like depression, headaches, fibromyalgia may come in. So this is where some of the things, when we tell you about exercise or meditation or yoga, we're trying to get you to also promote the release of your endorphins, and you generally continue to feel, good. Yeah, because when you feel more positive, you're able to do many other things as well. Since we're talking about hormonal issues, I thought we'd mention premenstrual dysphoric disorder. This will happen when most people will call it PMS. Here it's hormones are coming into play. We do have sometimes where we have patients admitted because of premenstrual dysphoric disorder due to their mental health issues as well. So they'll have severe fatigue, mood changes, anxiety, irritability. Others get very depressed, tearful, concentration. So you remember the hormone I mentioned, the neurotransmitter I mentioned called serotonin, usually may be the one that in some individuals have a problem there. For most women, usually in their cycle, you have changing levels of estrogen and progesterone and serotonin as well. So in the first half of your cycle, your estrogen levels might go up. And then the second half, it might go down. For many women, so not many women get premenstrual dysphoric disorder. So for many women, the level of serotonin remains stable. But for some women, as your estrogen is dropping, your serotonin levels are dropping. So during that period, you have severe mood changes and severe fatigue, a lot of anxiety and depression. So we do find sometimes there are patients we have to put on some medication during this period where they're having just before their menstrual cycle, the period checks in. So mostly it's just hormonal. Men are also not left behind, which is not a good thing. I might say it as if it's a competition, but it's not a good thing either. Because of your decreasing levels of testosterone, you get muscle loss, you get depression, irritability, your circle of friends has gone down, new life challenges. Remember, this is happening around the time someone is going on to retirement and proceeding onwards. So when we usually talk about young people being quite prone to getting depression and other mental health problems, so is the elderly. And we're talking about both men and women. But for men, it can be explained by a multitude of factors. The fact that your testosterone is going down, you're having a transitional period in your life, your circle of friends is shrinking as you go on, and then you're not feeling as challenged as you used to be. So that motivation and drive goes down. Yeah, so we call that andropause. So that happens also to men. For women, it's the menopause that also comes with a whole multitude of things. Remember, during that time, the estrogen levels are dropping as well for women. So they're more prone, if it's very severe, they appear someone who has severe PMS, what we've just talked about. So that can happen later in life, and we have to be wary. But they're transitional, especially for women. At some point, things level out. For men, sometimes, if we're not addressing the other challenges that are going on in their life, then things start to get out of hand. And it's nice for people to be aware that that can be coming in so that they can prepare as well. So when we're talking about preparing for retirement, you're not just preparing for financial security, you're also looking out for your mental health, mental well-being. Now that we've talked about what brings on mental health problems, we have different types of mental illnesses. Being individuals who come from the insurance side, you've seen many diagnoses that we write out there. So we have anxiety disorders. This is basically what we mean, anxiety, but it's severe anxiety and impairs your day-to-day activity. We have people who get what we call panic disorders that can really be severe, where you suddenly feel your heart is pounding, you can't breathe, you're going to pass out. You go to the doctors, your heart is fine, they've done all the tests are okay, but it keeps recurring. You might be having a panic disorder, which is part of anxiety disorder. Or you can have generalized anxiety where you worry about everything and nothing, you're barely sleeping, you're just ruminating, your mind is not shutting up. So, and it impairs your sleep, you're fatigued the next day, and it can also lead to other mood disorders, your concentration is impaired, you make mistakes at work, things like that. Psychotic disorders are more on the severe side sometimes, where people do hallucinate or start believing things that are really not there. We have severe personality disorder. We have personality disorders. For most personality disorders, someone will always think this individual has always been like that. However, you'll notice that even if they've always been like that, it impairs their relationships with others. Yeah, someone who may have chronic feelings of emptiness, the next time they're slashing things, they've, you know, and it occurs in periods, they're not psychotic. So those are personality disorders. Developmental disorders occur mostly in children. Okay, start in childhood and they can endure. So here we're talking about things like intellectual disabilities, attention deficit hyperactivity. Those things actually start from childhood and sometimes can endure. Eating disorders. We've started to see quite some eating disorders. Previously, we weren't seeing a lot. Here we're talking about something called anorexia nervosa, where someone sees themselves as fat, even if they're not. So you'll have an individual who is about already 40 kilos, but they believe they're fat and they will want to keep losing the weight. Others will try extreme methods of losing weight. Maybe they'll purge, they'll try and throw up, they'll use a laxative to do this. And then they have periods where they eat losing control, mostly related to self-esteem issues and depression. We have post-traumatic stress disorders. These occur when someone has been faced by a very traumatic event where you believe your life is in danger at that time. You've been through a very bad road traffic accident, umevamiwa na wezi nyumbani. So the sequelae or the aftermath of all that is what leads to post-traumatic stress disorders. So these are just a few of them. We have quite a number of other mental illnesses. So recognizing symptoms, you have to recognize. So remember I mentioned sometimes even when we were defining mental health, it's someone who is not able to live up to their full potential, yeah? So your day-to-day activities somehow have been impaired for me to say you have a mental disorder, and they've been impaired to quite some extent or for a long time, okay? So for mental health problems, for us to see they are a problem, you have to have distress to the person themselves or to those around. When we say to the person, to those around is because sometimes, and most of the time, especially with severe mental health problems, the person doesn't think they have a problem. That's why you have people being brought to hospital either by police or sometimes tied up or being conned and being brought to hospital. It's because they don't see or they're not distressed by their symptoms. We say sometimes when you see someone stripping naked at that time, they don't think anything wrong with them. But other people will see there's something wrong with this person. They behave differently from how they usually do. So this is a person who is very bubbly, talks, and then suddenly you see, or gradually you see, they're keeping to themselves, they're not talking much, they barely answer calls, they don't go out, things like that. They are danger to themselves or to others, so they're violent or something like that. There's a lot of dysfunction at family or personal level. Let's go, for example, with depression at work. You have poor concentration. You're not relating well with your family because you're self-isolating, and at a personal level, you're not looking after yourself in terms of hygiene. Your drive has gone down, things like that. And cultural appropriateness. So when we find all these things are not, they're not going as they should, those are signs of mental health problems. So distress to the person, change in personality or how the person is, or change in behavior, being a danger to themselves or others, or having dysfunction at work of family or personal level. Children are not spared in mental health problems. So this is just a few of the symptoms that we can get. And remember, we have a whole array of mental health problems. So these are just some of the ones that you may come across. Crying a lot, fatigued and unmotivated in someone who was previously motivated is a problem. Bedwetting when before there was none, or bedwetting and this is enduring. So maybe someone is at the age of 12, 13, they've never had a dry night. It can be either on a mental health side, or sometimes we still have to investigate for other things. They can have overwhelming fear. The child who was not fearful before, and suddenly cannot walk alone, they cannot do anything alone, they cling to their family. If the mother wants to go to work, they're very fearful. Poor feeding habits, they're not eating well. This is especially a poor appetite or change in eating habits. Nightmares in children, especially if they endure. A once-off nightmare, even for an adult, we wouldn't think much of it. But when a child keeps getting nightmares over and over, that's something we worry about. Severe mood swings, that's beyond your developmental age, for example. Impulsivity, high-risk behavior, where you just take off because you've been told to go for a trip to wherever, and then school no longer a priority, you have exams, but you take off. Heavy drinking, high-risk sexual behavior. Drug and substance abuse. So as I said earlier, someone can just start as experimentation, but then it goes out of hand. Or someone can be using substances to self-medicate from all these other things, overwhelming fear and sleep problems. Attempts to self-harm, attempting suicide, or even verbalization of suicide. That's a symptoms that you have some hopelessness is coming in and all is not well. What about at the workplace? How do you know if your colleagues are, maybe having problems? Especially if you notice a change, yeah? Someone who was very okay, or was on time, meeting deadlines, team player, and then you suddenly see they're withdrawing. They really don't care anymore. They miss deadline. They're not concentrating well at work, making careless mistakes for someone who used to be very sharp and very on point, inappropriate reactions, losing tempers, bashing walls. I think someone's still here. Strained relationship. Okay, I have an audience who's not with me somewhere. And increased stress levels. So other symptoms now, this more or less also at an individual level, when you have sleep and appetite changes, you have poor concentration, thinking and explaining, you have lost the drive. Used to wake up very, very early, nicely, prepare, go work out, then go shower and go to work. Then that initiative is no longer there. That morale is no longer there, feeling like you're out of sorts, feeling disconnected. Feeling like, so one of these, there's this for the exaggerated beliefs about personal abilities. That's a symptom, especially for some types of mood disorders like mania, like bipolar. Someone is very anxious or unusual behavior. Suddenly you notice your colleague is nowadays mumbling to themselves, gesticulating to themselves as they walk, and they don't have headphones on. Because nowadays we see that happening a lot to people who have their ears plugged all the time. So when you see such unusual behavior, then there might be a problem, or there is a problem. So when do you refer? As especially from the workplace, when do you tell someone, I think you need help, or you need to go to HR so that they can see where else to send you? If someone has all these things that we've talked about earlier, yeah, the signs and symptoms at the workplace, you may not have to, you can still refer maybe to someone. Most workplaces nowadays have a wellness center or a psychologist in place or a counselor in place. You can start there. But there are times where you have to send even more or less to other higher specialists other than just the work counselor and all that. Or even the work counselor should be able to send someone to a specialist when they find that they need to go there. So someone who's unable to look after themselves or their family. So that's a very big flag, especially for someone who used to be able to do that. Those at risk of self-harm, someone who's verbalizing, someone who's saying things like, ata nikienda, they don't have to say, I'm going to kill myself, but you can tell from the talk that they're having that things are slightly different. Their outlook to life is changing. I don't think I would be missed if I was to disappear. What's the point of continuing with this life if things remain like this? Such talk, then you should see that this person is at risk of harming themselves. Those at risk of harming others, yeah. Tempers are flaring at work. Someone has punched someone else. You don't have to wait for them to come and punch the second time, yeah. Punching at walls, bashing things, breaking things, or even verbalizing, I'm going to kill someone, or I'm going to hurt someone, or should that person do that again, I'm going to hurt them. That person is at risk of harming someone else. Those who are bereaved and seem not to be coping. So bereavement is when someone has suffered a loss of a friend or a spouse, or suffered a loss anyway. So when that happens, there are many people with just family support and social support are able to get through it, yeah? But there are some who really tend to struggle, yeah? It's been 6 months down the line and the person is still not with it yet. They're still really sad, not able to focus. Then those you should send to specialists. Those with an infected family member or an in distress, then you can refer, especially in this time. So we're talking in terms of COVID times, so that would really apply, or are in distress, or even in any other time when someone is going through, a colleague is going through a family illness or something like that, and they're really distressed about it. And especially in this time of COVID, those experiencing effects of stigma, yeah? Your friend of a friend that you talked about had COVID, and now everyone thinks you had COVID through the friend of a friend. Yeah, that's a little bit of stigma. Even with mental health problems comes stigma. HIV comes stigma. So those experiencing that then should be referred as well. So as we wind up, these are just things for you to remember, yeah, which I actually said when we were defining what is health. We said health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmary. And mental health does not mean that there's no illness there. So we're looking at, remember in the definition of health, mental health is mentioned. So you don't have to say it's not important because you're not having a physical illness, okay? Good mental health is achievable. Even those who have initially presented with severe mental health problems. You're working in insurance, so you know when we are discharging patients, they're better, yeah? So that means we've converted, or we've set you on to the course of from poor mental health to fairly good mental health. And as you go on, it becomes even super. You don't even, depending on the illness that you have, there are different modalities of care that are there. It is very common, actually. We say almost a tenth of the population has a mental health problem. And even now that there are many stresses going on, it could even be more than that, yeah? For some mental health problems, they are treatable, others are manageable, yeah, where you have to take medication for quite some time. I always tell people to look at, because I always get the question, if I take medication, will I be addicted to the medication that I'm taking? If I'm taking an antidepressant, will I be addicted to the antidepressant? I will always say it's like asking, is a diabetic addicted to their insulin kind of question? So, and then when we look at it, I always compare with a physical illness like diabetes or hypertension, where you have to take medication for a long time. There's some patients who have diabetes, they have physical changes in their lifestyle changes, and they find they go off their medication. Same thing with depression and some other mental health problems. We manage you, we get you off the medication. However, there are some illnesses that can recur. Early diagnosis and treatment is key to good outcomes. Presenting to hospital early so that you're not very severely unwell. And this applies to all illnesses, whether it's diabetes, hypertension, pneumonia, mental health problems are also illnesses and are not spared in that part. You present early, course of treatment is easier and outcomes are better. Present later, sometimes it's a challenge, you have longer hospital stays. And don't forget, physical and mental health go together. So I've mentioned about stimulating your endorphins, yeah? That's something you can do as a feel good. And when you're doing that, you're also promoting your physical health as you're promoting your mental health. When you have physical problems, you're more vulnerable to getting mental health problems. So they go hand in hand in very many spheres, okay? So that was basically our presentation. I leave you with some slides from our hospital, our various branches. We have one in Braeside, that's Chiromo Braeside. It has very nice cozy gardens. I think most of our facilities actually have nice cozy areas. We have the Westlands branch, and then we have the new hospital in Bustani. So you're welcome to visit, and I take you back to Gathoni. Yeah.
Thank you very much, Dr. Judy. That was really good. Indeed, mental health and mental illness is a global burden, with just looking at the staggering statistics where we have 1 in 4 people would have gotten a mental illness in their lifetimes. So that was really good, looking into the signs and sleep symptoms, small things that sometimes we tend to ignore. Any changes in sleep patterns, eating, mood, bowel movement, those investigative functions are very important. And also, more importantly, as has been emphasized, when do you refer somebody to see a practitioner? And remember, early diagnosis and treatment is key. Jackie Anundo, who is a senior clinical psychologist and currently the head of research and training at Chiromo Mental Hospital, will be taking over the moderation. And as she comes in, I would like to show you just a short video, 30 seconds. I don't know if you, can you see it?
Not yet. Share your screen? I didn't think you're
Yeah,
sharing it.
there. So Dr. Judy has told us about the facility. In case you are wondering where to go, this is the new facility. It's not.
No, it's actually.
Can you?
Yeah, it's going on. proceeding.
Welcome, Jackie. Jackie will be introducing Mr. Evans Olo.
Okay. Thank you very much, Gadoni, for that clip. Very informative. I believe that the participants have been able to see that indeed with mental illness, one can actually recover in dignity. The recovery in dignity starts with, first and foremost, the environment, and followed by the professional service that is given. So thank you very much for that clip. Thank you, Dr. Judy, for also that wonderful presentation. And indeed, we cannot talk about mental health without talking about addiction, because addiction has become quite rampant. And the next speaker is going to take us through that. At this point, let me introduce Evans Olo. Evans Olo is a guru in substance abuse matters. He's an addiction specialist. Evans also has a wealth of experience in counseling, followed by his training in clinical psychology. He is also the current president of ISAP Kenya chapter. And if you've done an addiction course, then I think Evans is the man to see, because you need to belong to that particular association. Evans Olo has also done extensive training not just in Kenya, but also in other countries. He has done substance abuse training in countries like Ghana, Nigeria, Vietnam, Malaysia, Kazakhstan, and even the Bahamas, and also extensively in Kenya. So we are privileged today to have someone with a wealth of experience, and I believe that we are going to learn a lot from his presentation. Evans Olo, karibu sana.
Thank you very much, Jackie, for those wonderful, kind words. Thank you, Gadoni, and thank you, Dr. Judy, for the presentation. Maybe, Gadoni, you will allow me to share my screen. Is that possible?
Yes, just go ahead and share.
All right, great. Thank you very much. Once again, as has been said, my name is Evans Olo. First and foremost, I'm a consultant psychologist, and I've over 15 years experience in the area of mental health and substance abuse or use management. I'm also the president of ISAP Kenya. ISAP Kenya is the International Society for Substance Use Disorders Professionals. It brings together over 10,000 professionals across the globe, And in Kenya, we bring together all those working in the field of substance use management. Once again, I'm happy to be here partnering with Chiromo Medical Center and APA to talk about substance use disorders. One of the things that, as Jackie and Dr. Judy have mentioned, is we cannot talk about mental health without talking about substance use disorders. In fact, when you look at the statistics, and I'm quoting from the report presented by the task force on mental health in Kenya through the Ministry of Health, it says that almost one of the 5 top most mental disorders that present in Kenya is substance use disorders. The others include, of course, depression, schizophrenia, and anxiety disorders. But besides that, it's also noted that substance abuse is associated very strongly with a significant disease burden, as well as a high mortality, actually it's the highest mortality rate among all mental and behavioral disorders. And this is seen through incidences like road traffic accidents, liver cirrhosis, and other medical conditions. Some of the conditions that the insurance firm deal with a lot. Other cases that are associated with this mortality and disease burden that is the result of substance use disorders include cases of overdose, death by suicide, as well as co-occurring mental and medical conditions. It is indeed true that substance use disorders tend to coexist with other types of mental disorders, key amongst them depression, anxiety, and attention deficit disorders. So one of the key questions that I think many people wonder, therefore, is if substance use disorder is responsible for such a high rate of disease burden and mortality, why then do people continue using substances, drugs, or even alcohol? The answer lies in understanding what substance use disorders is. And I think it's important that we understand what substance use disorders is all about, because it impacts on treatment, it impacts on intervention, it impacts on the duration of treatment and the costs implications. And I will quote the definition of substance use disorders from the American Society of Addiction Medicine. This definition has been accepted by many other professional associations, including, for sure, the Kenya Psychiatric Association, the Psychologist Association, and other medical associations across the globe. The American Society of Addiction Medicine, in short ASAM, defines addiction, and I will use the word addiction interchangeably here, as a relapsing disease. In fact, it describes it as a chronic relapsing brain disease characterized by compulsive use in spite of negative consequences. Let's pause for a minute and just think about what that means. Contrary to popular belief, addiction or substance use disorder is not a disorder of criminal behavior. It's also not a disorder of moral failing. You know, many people think that the person who is caught up in addiction has low self-will and poor morals. That's not true. It's now been confirmed that addiction is indeed a disease just like any other disease, because it has the symptoms and signs of a disease. It has a cause, it has a progression, and eventually, if untreated, it has its own prognosis and conclusion. When we talk about diseases, I'm sure we can think of diabetes, we can think of COVID-19, we can think of hypertension, on cancers. I want to surprise you if you have not heard this before. Addiction is a disease just like the diseases I've mentioned. But it's not just a disease, it's a chronic disease. And I've highlighted the key concepts that I want to mention in helping us understand what a substance use disorder is. it's not just a disease, it's a chronic disease. Chronic is something that is long term. And we know examples of chronic diseases. Diabetes is a chronic disease. Cancers are chronic diseases. These are diseases that in many situations really do not have a cure, but they can be managed. So addiction is a chronic disease, but it's also a relapsing disease. And this point is important for insurance and treatment interventions. Many of us think that once I bring somebody with substance use disorders for treatment, they should be okay 3 months down the line or whatever duration that they're taking in for treatment. But science has shown us that when it comes to addiction, just like when it comes to other chronic diseases, the potential for relapse is very high. And people who experience this usually wonder what is wrong with them. How is it that they have not benefited from treatment? And the same applies to those in insurance programs and those who provide those kind of interventions. We always ask, how come the person was taken to Chiromo, for example, or any other facility, and 1 year down the line, they're back to using? The answer is because addiction as a disease is a chronic relapsing disease. To illustrate my point, I just want to share with you a story that I once encountered, and this was the case of a teacher. The teacher had been employed for some years with the TSC, and because of alcoholism, he eventually was interdicted. So he spent roughly 1 year out of work, and he went through the treatment process. And after some time, somebody working at TSC noticed him. 1.5 years down the line, he had sobered up, he looked clean. And he asked him, how come you are not working? And he shared his story, and this person working at TSC was very, very impressed. He went back to TSC and talked to the bosses at TSC and told them, look here, I found somebody who used to be a teacher, is in recovery, is sober now. I think we can use him to talk to other teachers on the dangers of alcohol and drugs. And TSC was setting up a wellness section. So they discussed amongst themselves and they said, I think it's important we bring such a person on board. The bosses at TSC agreed. This lady went back to the person in recovery, got his papers, took it back to the bosses at TSC. They looked at the papers, he had all the qualifications, and they agreed to employ him. There was only one thing remaining, a formal interview, just to get to know the person. So an interview was set on a Monday morning to come and meet the bosses at TSC. So the person was informed and was, of course, very excited. Monday morning came. The meeting was supposed to be at 9. 9 o'clock, everybody's gathered in the boardroom. 9:10, no one has showed up. 9:20, 9:30. They waited for roughly an hour until the bosses said, you know what, we cannot wait any longer. Just before ending the meeting, this person staggered into the meeting, drunk. Of course, he did not get the job. But that story illustrates the relapsing condition of addiction. It is so sad that many people in addiction are caught up with always trying to move forward by finding themselves unable to do it. And that is because addiction is a relapsing condition. But it's not just a relapsing chronic disease, it's a brain disease. We actually say addiction is the disease of the brain. And the reason for this, unlike other problems, addiction presents with a challenge of affecting the brain chemicals of the brain. When we ingest alcohol or take drugs, or we smoke weed or shoot heroin, whatever drug of choice we take, it does go to the brain through the bloodstream. And when it gets there, we say that it crosses a very important barrier in the brain, something called the blood-brain barrier. And when that happens, then the tiny chemicals that make up what is alcohol, or the tiny chemicals that make up what is marijuana, or the tiny chemicals that make up what is heroin, start to affect the brain. Now, that is the reason why the person with substance use disorder struggles to understand stuff, struggles to make resolutions stand, struggles to keep their word. Because as we know, the brain is the seat of many things. In fact, we say that the reason why you are able to hear me is not necessarily because of your ears. It's because of your brain. Your ears allow the sound, the brain interprets what is going on. The reason why you are able to see anyone or to laugh or to control yourself is because of the brain. And Dr. Judy mentioned some of the chemicals in the brain. Now, the funny thing, when we take drugs or alcohol through the mouth, through whatever means, through smoking, they go to the bloodstream and go to the brain. That is why we say addiction is a relapsing brain disease. But what does that do? What that means, therefore, is that because of that, persons with substance use disorders will engage in compulsive use in spite of negative consequences. We all know of people who have been warned that I will sack you if you continue drinking or using, but they continue drinking anyway. You will die if you continue using because you have a liver problem, but they continue using. That is because the disease of addiction denies them the opportunity to make rational choices. In fact, it makes them act compulsively. And that also is the link between substance use disorder and mental disorders. Think about it for a second. Just think of the story I've given you. Who in his right mind, after 1.5 years without a job, getting an opportunity to get back to work, would still go back and drink? My answer is no one, unless, of course, they're not in their right mind. Unless, of course, they are sick. Who in his right mind will risk his job because of alcohol and drugs? Who will in his right mind will drink the school fees of their children? Who in his right mind will drive drunk and cause accident on top of previous accidents, putting their lives at risk? No one, unless, of course, they are sick. And that, therefore, is something we usually forget, that the person with substance use disorder is not normal in the sense that we understand normalcy. There is a problem because they're putting their lives at risk. Something is not right. That understanding is important, simply, if nothing else, in treatment and what we can do. How then do we pick out persons with substance use disorders? Now, there are a number of signs and symptoms that are presented that we could look at. And one of the things that is known now is that the symptoms and the disorder can be understood along a continuum, from mild to moderate to severe. What I want to do is to share with you these symptoms, but I want to share with you along a progression, and a progression from early experimental use to full-blown addiction, and what the implications are. Hopefully, this would help us to intervene at different stages of the progression. Of course, we say that no one ever gets addicted, or no one ever suffers from substance use disorders if they did not start in the first place. So of course, the starting point is to start. And we know people will experiment with different types of drugs. But after some time, even those who experiment may get into what we call occasional use. That is the early stage of the progression towards full-blown addiction. In the occasional use, we call ourselves the social drinkers or the social users. And in this situation, it's a situation where people drink on occasions. We drink during birthdays, and we drink during end of year parties, and we drink during funerals for many of our cultures. And we drink whenever there is an occasion. This kind of person does not drink all the time. They drink occasionally.
Evans, may I interrupt you briefly?
Yes.
Your slides are not moving. Kindly do slideshow and then try to move the slides.
All right. As from where?
We are still on the first slide, so we have not moved at all.
Oh, we have not moved at all.
Yes.
All right, let me try and do that again. Thank you for that.
Sorry
Let
about
me
the
just
interruption.
It's okay, it's okay. Let me try. All right. Any change now?
We can see the transitional stage slide.
All right.
Kindly do slideshow.
All right, I'm trying. I don't know why it's not picking. And show.
Sorry, Dr. Evans, you have to click on enable editing first. Is
that that is what is stopping it. All right, sorry. Yes, okay, great. Okay, so
There you are now. Yeah, now it's okay.
Now it's okay.
Yes.
All
yes.
right. So you did not see many of the things that I was talking about, but let me pick it just from here.
All right.
Thank you for that technology sharing. So I was saying that early stage occasional use, and this is the kind of person who will use either alcohol or drugs occasionally. They may also occasionally use a lot of it, what we call binge drinking or binge using. It's a person who waits until the end of a very difficult task, either at the workplace or at the end of a tough exam, and they will use, but they don't always use. Now, unless, of course, it has impact on their functionality, on their ability to relate with others, on their ability to go to work. We usually say at this early stage, the problem is mild. But of course, we know that binge drinking can have serious consequences. In fact, one of the things that is said is that drinking regularly is better than drinking once heavily. But of course, at this stage also, there is occasional use to deal with issues, what we call a psychological escape. Individuals learn that they feel good when they drink when they're bored, and they feel good when they drink when they want to perform certain tasks, when they are feeling a bit low. So those are the early signs and early stage of the progression towards addiction. An important thing that happens at this stage is that people tend to develop tolerance. This is where you no longer feel how you felt the first time you took the Tasca or the first time you smoked weed, because weed is being smoked a lot. And therefore, people tend to increase the amount of the drug of choice they take. Tolerance means that the body is slowly accepting the presence of the drug or the alcohol in their system. Early stage, the key thing about it is that while the signs are those ones, key amongst them is tolerance, it's usually done occasionally. Then, of course, we move to the next phase together with the signs and symptoms. This is called the transitional stage, also the problem concern stage. Because of tolerance, people tend to increase the amount they take, than the time they spend drinking or drugging. Now, usually what that means is that it's going to start interfering with the other responsibilities the person does. That is the beginning point of problems. The first stage is not necessarily considered the beginning point, but this is the transition from just what is mild to what is now considered problematic. There is an increase in the amounts. There is a lot of time spent in seeking out the drug, to the extent that the person may not start coming to work. But also what is seen is that there is recurrent problems, and the recurring problems could be psychological, social, or even physical. This is where the person starts going to hospital with chest pains, with coughing related problems, with stomach-related problems. I cannot sleep well, all to do with the drug or the alcohol that they're taking. Or this is where somebody starts to get arrested. The conflict begins at home. And the reason is people begin to notice. Dr. Judy mentioned that once you notice the change of behavior, this is where people start to notice that you're no longer that sharp person you used to be. You are no longer that person who used to hang out with us. You're no longer that person who used to come in early. Critical at this stage is the individual starts to violate their own values. You start doing things that are not and have not been associated with you. One situation that I've seen and I've heard people say is that you go out and you don't come back home. Instead, you end up in somebody else's house. And by that, I mean in somebody else's bed. So you start violating your own values. And of course, people start to question themselves at this stage. This stage, to get to this stage actually can take a lot of time. Not just months, it can take years, but it is a gradual progression. Then we get to the end stage. Now, this is where we talk of the person has severe substance use disorder, or what we call addiction. And some of the symptoms and the signs you will notice about this person is that they will have loss of control. What is loss of control? It's not loss of control of their behaviors. It's loss of control in their drinking or dragging. Somebody will say, let me go and have one, then I come back home. They end up having 5. That was not the plan. Let me go home, but they end up passing through the pub and staying there until morning. That was not the plan. So that is one of the indicators that the alcohol and drug is becoming a problem. They have what is called the morning drink. For them to feel normal, they start taking it before doing anything else. What we, in local parlance, we refer to as kutoa lock. So that is what happens at this stage. Blackouts. Now, blackouts is not passing out. Passing out is drinking until you faint, as it were. Blacking out is having gaps in memory. You can no longer remember what happened last night. You know you went out, you know you started drinking, but you don't know how you got home. You have gaps, very big gaps of how your day was and where you are and what you did. And with these blackouts, people start to make up stories to explain those gaps. And for those listening to those stories, we start wondering what is wrong with this person. They give such outrageous stories about where they were and why they did not come back home or why they did not come to work. Withdrawal symptoms. Here is where for those who drink, they will experience either shakes, nightmares at night, sweating a lot. For those who take opioids, every time they stop, they may have cramps and pains and vomit. So withdrawal appears every time the person does not take the drug of choice. Like I said, there is also continuous use despite the consequences, despite the warning. Risky behavior. People start doing things again that puts their life at risk. Critical at this phase also is that there is numerous failed attempts at stopping or even cutting down. People make New Year resolutions. People say, this time I will not. And they initially try not to reduce, but they get to a point where they say they completely will not take. But it fails. Now that says something, that you are no longer in charge of your drinking. The drinking is now in charge of you. And that is the disease. That is the disease that is taking on. One of the important things that science has discovered at this stage is the noticeable physical changes that take place in the brain. What you're seeing in front of your screen are 2 images of brain that have been scanned. The one with blue, a lot of blue, that is the brain of the alcoholic, the person who has been drinking for a long time. The one with many yellows and reds, that's the normal brain. That is your brain and mine, I'm assuming. But what this tells you is that these are images of brain activity. As you can see, when we don't take alcohol and drugs, and this is just for alcohol, it's the same when it comes to other drugs. The brain activity is high as indicated by the yellows and the reds. But after some time of taking alcohol and drugs, the level of brain activity goes down. That is just one slide. I also want to show you another slide, a different slide, a cross-sectional slide. Again, this is the brain, the one normal with more blues and yes, less black, and the one with the more black is the brain scan of a 43-year-old alcoholic. What you notice, therefore, is that when we take drugs, like I said, addiction is a brain disease. We ingest them either through smoking, through drinking, or through injection. Whether we eat the cookies or we smoke the weed, it gets to the bloodstream and it is distributed to the brain. In the brain, it crosses the blood-brain barrier, and that is what happens. So when this happens, and like I said, the brain is the seat of many functions. No wonder the person you are trying to tell, look, don't drink your child's school fees, is not going to listen. There is a problem at the brain level. No wonder the person is going to act compulsively. No wonder the person is going to continue drinking, because there is a physiological change, a neurochemical change that has taken place in the brain. Those are some of the symptoms, and at a physical level, that is what we see. And that is what makes addiction a relapsing chronic disease. Of course, the question finally that I want to talk about is, what then can we do? Whether in the family, whether at the workplace. They say that prevention is always better than cure. I guess the first thing that we can do is to prevent progression towards full-blown addiction. How? By raising awareness. I have sat with people in treatment facilities over the 15 years or so that I've been in the field. And I've had them say that if only I knew, if only somebody told me that this is what weed will do, I would not have taken it in the first place. What we are doing now is important because we are raising awareness. It is part of prevention. We need to help people know the dangers of substance use disorders, what it does to the individual at a biological level, what it does to them at a psychosocial level, and the relationship it has with mental disorders. In the workplace, therefore, doing more of this is important. Just raising awareness as part of wellness, that is important. At the home front, prevention means that we provide environments that reduce or minimizes vulnerability to start using alcohol and drugs. Accessibility to drugs and alcohol. Many people now are using at a very early age. But also the issues in the home front. Research now has shown that something called adverse childhood experiences, those are the negative experiences that people go through as children, is one of the risk factors for starting to use alcohol and drugs. And these include dysfunctional home environment, trauma-related experiences, dealing with persons with mental health disorders, or dealing with a parent who's incarcerated. The more we reduce these negative home influences and home environment, the more we reduce and prevent starting up taking alcohol and drugs. For those of us who must drink, and I know many of us drink, and we're not saying you should not drink, then what we need to do is to minimize harm. Again, it was said that if you don't take too much and you don't go through the progression, then you will not develop full blown. In the area of alcohol, minimize harm include, according to WHO recommendations, taking 2 Taskas per sitting for males and taking 1 Tasker per sitting for females. And the reason is there is a biological difference in the breakdown of alcohol between male and female. Female biologically should not drink as much as men. So reducing harm is going according to WHO recommendations. I know that can be challenging for many people, but it means if at all you must drink, just drink 2 in one sitting. That is 2 beers, or just drink 2 glasses of wine, not a bottle, glass, or just drink 1 shot of whiskey. If you must drink, that reduces harm. There are many other ways of reducing harm. Eat before you drink. Do not mix brands. Those kind of things. For those, again, in the workplace and in homes, and this therefore is also to do with the insurance intervention. We need to change our attitude towards persons with substance use disorders. Like I said, no one in his right mind wants to harm themselves. They may have started out wanting to drink and use, but once you develop the disorder, it's no longer you are in control. Therefore, we need to accept and support. And it takes time for them to get back on the road to recovery. We need to be careful in the workplace that we do not enable the behavior or even develop codependency. The same applies in families. You know, people who live and work with persons with substance use disorders tend to believe that they're trying to help them by doing certain things. Unfortunately, there are actions that we engage in that purely leads to enabling of the behavior to continue. Bailing out your loved one when they find themselves in problems because of alcohol and drugs. Transferring work from one employee to another because the employee was given has not come. So we are burdening somebody else with that work, and we are allowing this other one to continue without check. That is called enabling behavior, because people learn, oh, so I can continue using and drinking. There is no problem. And also to be careful as those who live with people with substance use disorders, that we do not develop what is called codependency. Codependency is actually the disease developed by those people who take care of persons with substance use disorders. Because we are worried for them. We are not able to sleep when they don't come at night because we imagine something bad has happened to them. We are frightened every time we receive a phone call in the middle of the night because we wonder, is that the police or is that the mortuary? So that we develop new problems, anxieties, lack of sleep, simply out of concern for the persons with substance use disorder. Now, I'm not saying we shouldn't be concerned, but I'm saying we should be careful that that concern does not develop in a problem in us. We always say this, that while the person with substance use disorder is addicted to the drug, the wife or husband or child of this person is addicted to the addict. That is called codependency. Finally, as Dr. Judy said, there are points where we can do a few things to help and prevent, but there's a point where the person is no longer the kind of person we can help. The person has an illness that needs professionals to handle. And we say it would be good to refer them to professionals, to a place like Chiromolen, for example, to treatment professionals and counseling and clinical psychologists, to provide them with the treatment based on understanding of how addiction works. What works, what does not work. Beating them, cajoling, arguing with them does not work, will not help. So those are some of the things I think we can do as people in the workplace and family members. And I guess the central message that I wanted to send today is that addiction and substance use disorders is not what we thought it was. It's actually a disease of the brain. And because it is a disease of the brain, we need to understand, be more empathic, compassionate when trying to help them. But also, we can prevent through early detection, put prevention measures, and where it's not possible, refer to professionals to help and handle. Professionals like those at Chiromo Lane Medical Center. So thank you for listening, and over to you, Jackie and Gathoni.
Okay. Thank you so much, Evans. Wow, that was a wonderful presentation. And I believe all of us in this webinar, we know someone who needs help. It may be our loved one, it may be a neighbor, but we know someone who needs help. And thank you for also telling us that, you know, this is a brain disease. Yeah. And so when we see people relapsing, we should not think that we've wasted our money in helping them. We should understand that it's part of recovery. And thank you also for letting us know that actually sometimes when you think we are helping, we are actually enabling the problem. When I think that I'm paying a bill for someone because I don't want them to be arrested, I'm actually enabling the problem. Yeah, so thank you for highlighting that. So it's important for us to take this message home so that we may reach out to those people who need help and get them professional help. So thank you so much, Evans. You can take a breather as I go through the questions. I think I'll start with Dr. Judy. Dr. Judy, you can hear me?
Yes, I can.
Okay. So Dr. Judy, there are a couple of questions for you. I know you talked about the issue of genes as a cause of mental illness, but there's a question that has come up. Could you just explain again whether mental health can be genetically transmitted?
Okay, thank you very much, Jackie. Yes, so there are some mental health problems that we see quite highly can be genetically transmitted. Here we're talking especially things like schizophrenia or even depression and mood disorders. So what happens most of the time, if you have someone who has a mental health problem in your family, you're more at risk of having a mental health problem. I'll give an example. Sometimes it depends on also the amount, for example. So something like schizophrenia, if you have a twin who is identical to you, who has schizophrenia, you're almost at 50% chance of getting schizophrenia. If you have a parent, if you have a fraternal twin who is not identical, the risk is slightly lower. If you have both parents who have schizophrenia, then you're even more likely to get schizophrenia. So some illnesses do go like that. And I will give we always say, I like comparing mental health problems to physical problems, just to make it almost like an even playing field. Think of when you have a relative or when someone has diabetes and they go to see their physician, the physician will always ask them, or they have symptoms similar to diabetes, will ask them, is there someone in your family who has diabetes, for example? So there are many illnesses, not just mental health problems, where there's a genetic predisposition to getting them. So if you have, if there's a person in your family who has diabetes, for example, you're at higher risk. But that's not to say that because there's someone who has diabetes in your family, you will definitely get diabetes. Same thing applies to mental health problems. Just because you had someone who has schizophrenia in your family or your brother has schizophrenia does not immediately translate that you will get schizophrenia, but the risk is higher. So it's not cast in stone. In mental health, we also have environmental factors, things that will trigger the onset of an illness. So there are times when maybe loss of a job can trigger the episode of a mental health disorder, which end up becoming chronic to start. So yes, Jackie, there is a genetic predisposition to mental health problems if someone has a family history of mental health problems, but not to all, but some, yes.
Yeah, thank you, Dr. Judy. Another question for you, and I'm happy that Florence has brought this out very clearly, that the greatest challenge I have experienced on mental health is on getting the victim to see a specialist. And then she goes also to tell us that most of us think mental health is equal to madness. And even before you answer that, Dr. Judy, I'd like to say that there are certain terminologies that we no longer use in mental health, and madness is one of the terminologies that we no longer use. And thank you, Florence, for highlighting this. So Dr. Judy, kindly answer that.
Okay, thanks, Jackie. I'll start with the terms, madness, you're crazy, olodo in different things, alichizi, things like that. Most of them are they degrade the person. So themselves promote stigma. We used to have, even us as individuals, we also learn with time. We used to call people who had, or even the terminology that used to be previously used for those with intellectual disability, whose IQ is below par, we used to say they have a mental retardation. We find the term nowadays degrades the person. So we'd rather say an intellectual disability. Same thing with when people used to say madness or things like that. Even now, unfortunately, you still see medical professionals still use such terms. So we'll use terms like mental health problems or mental illness, things like that. It kind of takes down the stigma towards it. And so in my presentation, to answer now the other question, I gave an example of someone who goes somewhere, removes their clothes, and then they don't think that's a problem. That's the unfortunate thing sometimes with mental health problems. They lack something we call insight, where they're not aware that they have a problem at that time. However, not only that, then the stigma comes in. For some reason or for many reasons, people don't want to be known that they had a mental health problem or that they saw a psychiatrist. So even if they have obvious issues, they will be reluctant to go and seek care. This is someone who hasn't slept for 5 days. They will still feel they don't want to go and see a mental health practitioner because of the stigma attached to it. So 2 things: stigma, not being aware that you have a problem, are most drivers to your question, why someone would be reluctant to seek help. But approaching it with empathy and slowly telling the person that this is how it's impairing their day-to-day functioning, most of the time gets them to come to hospital. There are some illnesses where it's very severe. For example, when someone has bipolar and they're in a manic phase, they're a danger to themselves or to others, or something like schizophrenia, where they're totally not aware that they have a problem. Some, unfortunately, have to be taken forcefully under the Mental Health Act to protect themselves and the public. So they are taken for treatment by force. But hopefully, we always hope that it doesn't get to that with all this education that we're giving, that someone is able to recognize there's a problem early enough and then be taken to care in a more humane kind of way rather than being forcefully taken.
Thank you, Dr. Judy. Evans, the next 2 questions are for you. Please tell us more about the enabler and codependency. Can these people be helped when someone is admitted in a rehab? Do the enablers also need to be admitted to be helped? Question number 2 is about the brain status. Is there a check? And what is the name of that test for us to be able to know our brain status?
All right, so thank you, Jackie. Starting with the brain status, actually the scans that have been shown are the result of many brain scans amongst people who were having challenges with substance use disorders. So it is possible to go for brain scans to find out whether there is a structural problem with the brain, common with many people with mental disorders. That is one of the first steps that is done to check, could the behavior be the result of a structural brain, a problem with the brain, or a growth in the brain, or problem with the brain metabolism. So people can check that to find out whether that is influencing their behavior. But I want to point out that the changes in the brain structure, or even the changes in brain metabolism, may not necessarily be the cause of alcohol or drugs. It could be the result of many other factors, but there is opportunity for one to do that. One can do what is called SPEC scans, or even magnetic resonating scans to see what is happening with their brain. On the question of enablers and codependents, the enablers can be helped to be aware that their actions are not necessarily helping the person with substance use disorders. While their actions may be out of best intention, the consequence is that it continues the behavior of the person suffering from substance use disorders. So the key understanding that we communicate to persons we describe as enablers is that you cannot change that person. You can only quote unquote pray for them and accept that they have a condition, but allow professionals to help them. So that is one of the things that we tell the persons suffering from enabling behavior or those with codependency issues. You cannot change the person. Therefore, while you have concern for the person, don't stop living your life. Don't do actions that remove them from taking responsibility for their actions. Yes, treatment for substance use disorders also include family members. So they need to understand what their loved ones are going through. They need to understand what they can do to change the family dynamics and therefore help the person in recovery. So most programs do have a family component to it that involves two things. One, family therapy for those trained in the area of family therapy, but also family sessions so that they can understand the dynamics of their loved ones and the nature of the disease that their loved ones are experiencing.
Okay. Thank you, Evans. The next question is to Dr. Judy. Dr. Judy, you know that during COVID, we've been doing a lot of hand washing. We know that OCD is a mental illness, a mental disorder. So do you think that the continuous, the persistent hand washing can predispose us to OCD?
Okay. Well, I will not say, so one of the things, OCD, for as many people will mostly know the OCD part, the one that comes in with being a germaphobe, for example, but OCD is a spectrum and there are very many, many things, many obsessions that people can get with, yeah? So being, fearing dark or feeling contaminated is just one of those things. So no, I don't think frequent hand washing would predispose you to having OCD of the contamination type. But I think it makes the person who has that type of OCD extremely anxious and even validates more and more of their obsession. So it makes it, they get into a tougher mental health space, where here is a man who believes that I have to wash my hands 7 times to remove just regular germs or something like that. Now throw in COVID-19, so they get an extra push towards their compulsion. So it will not trigger you to get OCD, but it will make you more vulnerable. If you already are having OCD, it might make OCD of that type, it might make it a bit worse for you.
Mm-hmm.
Yeah.
Yeah. Thank you, Dr. Judy, for that. There's also another question here to Evans. This has come privately. Evans, I didn't know about ISAP, and I didn't know that there's a difference between a counselor and an addiction counselor. I thought any counselor can be able to treat an addict. Please clarify.
Very good question, and thank you, Jackie. Not every counselor can treat an addiction problems. This is because addiction is a paradigm shift as far as some of the issues that counselors deal with is concerned. We say addiction is a multifaceted problem. It includes medical condition, it includes psychiatric condition, it includes the individual spiritual condition, it includes psychosocial issues. So one needs to be trained to understand the dynamics and the implications of those different conditions. And because of that, ISAP comes in to knowledge share with people who are in that field be they psychiatrists, physicians, counselors, psychologists, to understand first and foremost, like you have said, that they're not just dealing with psychosocial issues or issues of the willpower. They're dealing with, in a very great extent, almost a medical issue. They need to understand they're dealing with a disease of the brain. They need to understand they're dealing with a mental health issue as well. So there is a difference between an addiction professional and a general counselor or psychologist. Addiction professional has more certification in the area of addictions and substance use management. And that is where ISAP comes in. ISAP comes in to knowledge share, to provide training and capacity to individuals who primarily are in the field of substance use prevention and management.
Thank you. Thank you for that clarification, Evans. So we have come to the end of that Q&A session. I'd like to tell the participants that rest assured that you're going to get this information. We are recording, and all these will be posted on the social media pages for those who have missed. So if you have a colleague who has missed, the colleague will be able to follow it through the social media pages. To Dr. Judy, who is a child psychiatrist, thank you very much for the presentation and also for the questions that you have answered. To Evans, who is the ISAP president and also an addiction professional, thank you so much for enlightening us in the area of addiction. So at this point, I'd like to take this session back to Agnes to close it for us. Agnes, over to you. Agnes, or the contact person from APA, kindly close the session for us.
So this is Florence.
Right, Florence.
Yeah, this is Florence on behalf of Agnes. Thank you so much for the key learnings that we've actually had this morning. Personally, where I sit with Agnes in HR, we get challenges from our colleagues. I mean, sometimes even ourselves. So, and that's why I raised the issue of, like as I was going for tea this morning at the tea area, somebody said, oh, but that session is about madness and mad people. And I told him, I think we are all mad, and thank you for teaching me now about that word. It's derogative for sure. So, I mean, like we all have something that disturbs us or that could lead us to that level. So it's just about the extent. And what I would beg us is if you ever need help, please feel free to talk to care team, feel free to talk to HR, so that then we can also guide you to the relevant authorities, because we may not be experts, especially at HR, but we have Lucy Kuria's team, we have Kina Zainab, who are really able to send you to the right people. So thank you very much, Daktari. Thank you very much for the sharing that we've had, and we look forward to a lot more. So I think we can end the meeting there, and if somebody has questions, you can keep on sending them to us. We will forward them to our doctors to help us answer. Thank you so very much. So I think we can all leave the meeting at our own leisure.
Thank you, Florence, and have a good day. And the rest
You
of the
too.
Thank you.
Thank you very much.